as I said, that there is a one research which shows that when patient die with this Alzheimer disease, and when the cut section is performed, okay, when the autopsy is performed in the brain region, and that shows that there is a less acetylcholine, okay. So acetylcholine concentration is less, okay, and as I said you that the acetylcholine also help. They have so many functions, but one of the functions is to you can say help in the neuroplasticity, means help in the synapse formation, or basically a memory formation. Got it? So if there is a less acetylcholine, the memory loss, long term or short term memory loss will be appeared in this diseased person. Now, why this happened? What's the etiology? Why this happened? The answer is very simple, that the acetylcholine is basically present in the synaptic vesicle. Basically, all the neurotransmitters are present in the synaptic vesicle of the presynaptic neuron. This is the presynaptic neuron. Okay? The presynaptic neuron ending. This is the postsynaptic neuron ending. Fine? And here the neurotransmitters are kept. And here, this time the neurotransmitter is the acetylcholine. Now, when the appropriate impulse come through this axon area, okay, which result into the intracellular influx of the calcium ion, okay. In the presence of calcium ion, there is a synaptic fusion, okay. There is a synaptic fusion, and the acetylcholine is released. Acetylcholine is released. Now, here is the presence of acetylcholine receptor called as the muscarinic receptor, nicotinic receptors. Fine. So here the receptors are present. Now, this acetylcholine, okay, which is released from this synaptic vesicle or presynaptic neuron, basically, which will bind over this receptor. Okay. I should change the color. It bind over these receptors. Fine. Now, all the receptor is finished. Okay, all the receptor is occupied by the acetylcholine. Fine, but you know that all the receptor is occupied, and still there is a acetylcholine present. Okay, acetylcholine is secreted in this region. Acetylcholine is secreted in this region. Acetylcholine is secreted in this region. Fine. So for extra acetylcholine molecules, or you can say the hormones, there is naturally one enzyme is present which will break the, you can say, the extra acetylcholine, and this enzyme it is called as the acetylcholine esterases. Okay, this enzyme is called as the acetylcholine esterases. Now, this enzyme break the acetylcholine into the two part, as we seen. The one is called as the acetate, okay. Another is called as the another one is called as the choline. Now, this acetate and choline, it is again reuptake by the presynaptic neuron. This is the normal physiology, okay, normal physiology. But what happened here? There is a too much breakdown. Okay, there is a too much breakdown of the acetylcholine. Okay, so if there is a too much, you can say the breakdown by the activity of this enzyme called as the acetylcholine esterase, it means there is a less acetylcholine available to bind over this receptor. Means there is a problem in the, you can say, the impulse transmission, message, you can say the transmission. Fine, there's a problem. That's why people will develop the memory problem. That's a one hypothesis, and this hypothesis is proved, okay, by the administration of a drug, okay, administration of the drug, and that drug is called as the acetylcholine inhibitors, okay, acetylcholine inhibitors. Acetylcholine inhibitors. Fine, no problem. Now, one of the we will see in the management, under the management we will discuss the drug, but one of the drug is called as the Yeah, donzepil. Donzepil is the one choice of drug, okay, and there are others. There's a two classification we will see in a few minutes. One is called as the competitive inhibitors, one is called as the non-competitive inhibitors, okay. So this is the one main, you can say, the pathophysiology about the Alzheimer disease. So let's quickly understand what are. First one is the senile plug formation. Senile plug formation, okay. The another one is called as the neurofibrillary tangles. Neurofibrillary tangles, okay, along with the angiopathy, okay, beta amyloid deposition over the vessels. Then we have this acetylcholine, you can say the less, basically you can say the cholinergic nerve damage, okay, cholinergic nerve damages. Okay, so this is the basic pathophysiology, and drugs are designed in such a way that manage these conditions. The one of the, as I said, the managing the, you can say, cholinergic nerve problems, we have the drug which inhibit the activity of this enzyme called as the acetylcholinesterase. Okay, an example is the donzepil. Okay, rivastigmines. Okay, these are the certain drugs which basically you can say some we will see, but for a while you just understand, that enzyme have the active part, okay, and there are some, you can say, the pockets. So some drugs bind over the active part, that is called as the competitive inhibitors, and some will start, you can say, adjusting or sticking in the other side of the enzyme, that will result into the degradation of these enzymes. That's the drug pharmacology we will see in a few minutes. Understand now how you can diagnose the Alzheimer disease. That's a fundamental question. How you will diagnose the Alzheimer disease, that person is having Alzheimer. What are the clinical investigation, the diagnostic evaluation? So for sake of the diagnostic evaluations, we have very less initially. Yeah, it's a genuine fact that initially about this disease there is a very less diagnostic, you can say, the evaluations. Okay, very less diagnostic evaluation. But for now we have so many techniques. Okay, the one way to diagnose this Alzheimer disease is to study the CSF. Okay, study the cerebrospinal fluid. Now another is PET, okay, called as the progesterone emission tomography. Okay, so the one test is the CSF. Okay, by the CSF investigation you can understand the quantity of beta amyloid, you can say, protein. Okay, if there is a low level of beta amyloid, you can say, present in the CSF, it means person is having the Alzheimer disease. Got it? Another one is called as the PET, progesterone emission tomography. In this test, this is basically an imaging test. In this imaging test, we will put some radioactive tracers, okay, which will bind over these beta amyloid bodies, okay, with beta amyloid body, and give the, you can say, the evidence of this Alzheimer disease. Fine. Recently, there is a one great discovery, okay, which comes under the paper NIA, National Institute of Aging, which shows that now we have the blood test, okay, blood tests by which we can diagnose this Alzheimer disease, we can diagnose the Alzheimer disease. But right now, this is only, you can say, limited to the white population, but soon because it will come into for the all entire population sooner. Fine. Now come to the other point. Apart from these, you can say, the biochemical or lab investigations, we have also the history collection is very important for diagnostic evaluation. History collection have the paramount importance. Okay, then We have, you can say, the some of the tests, okay, which implies the you can say the brain function intellectual capability testing, okay, intellectual capability testing called as the neuropsychiatric tests, because psychosis also develop in the late stage of the Alzheimer disease, okay, late stage of the Alzheimer disease psychosis also occurs. Fine. So for the, you can say, for the test we have the neuropsychiatric tests, okay, some of the cognitive test, cognitive and mental examination test, okay. So once again, what are the, you can say, the investigation or for investigation or diagnostic evaluations, we have the CSF. Okay, we have the CSF. If there is a less protein, beta amyloid protein is present in the CSF, it shows that person is having the Alzheimer disease. Then the PET, progesterone emission topography, injecting the radioactive dyes or tracer, which will form the clear image evidence about the Alzheimer disease. Then we have the blood test. It's the recent discovery published in the NIA, funded by the NIA. Okay, published in 2022. Got it? No problem. Then the history collection have the paramount importance, because as I said that 90% of the Alzheimer disease, it's occurred just because of the genetic problem. Okay, the genetic inheritance basically. Okay, and rest are the sporadically, okay, which occurs instantly, irregular, infrequently. So that's why the history collection have the very important. Then neuropsychiatric tests and the cognitive and mental ability tests are some of the investigation. Now let's move forward and understand about the management, okay, how to manage this disease. Now coming to the management of the Alzheimer disease, how we will manage the Alzheimer disease. See, as I said you initial part of this lecture, that Alzheimer disease is not a completely curable disease. It's not a completely curable. Okay? It means we only can, you can say, help the patient, okay, help the patient to, you can say, by both the means. See, we discussed that in the case of Alzheimer disease, there is a, you can say, problem in the cognition phenomenon of mind, brain, okay. There is a problem in the behavioral, you can say, phenomenon. Apart from that, there is also a social withdrawal, okay. Social withdrawal is also one of the symptom of this Alzheimer. Got it? So there is no any, you can say, permanent treatment which can reverse back the disease condition, which can completely cure this Alzheimer disease. So we will basically provide the combination of, okay, doctors basically provide the combination of pharmacological as well as non-pharmacological, you can say, aspect, okay, pharmacological and non-pharmacological. For understanding the pharmacological aspect, we have certain, you can say, the category of drugs. As we discussed, the one category of drug which will inhibit, you can say, the cholinergic enzyme, that is called as the choline esterase. Break down the choline, okay, it's break down the acetylcholine. So we have the acetylcholine esterase inhibitor, and it's fall into the two classes. It have the two classes. One is called as the competitive inhibitor. Competitive inhibitors, okay. Another one is called as the non-competitive inhibitors. Non-competitive inhibitors, okay. Under the competitive inhibitor, one drug came and comes. This drug is called as the galantamine. And under the non-competitive drugs, we have the rivastigmine, and donzepils. Okay, these are the choline esterase inhibitor. It basically, you can say, inhibit the function of acetylcholine esterases, which we have the function of breaking the acetylcholine. Then we have certain drugs which block the NMDA receptor. NMDA stands for N-methyl D-aspartate receptor antagonist. So we have the one example which is the first choice of drug in the management of Alzheimer disease called as the memantine. Memantine is basically help to manage the neuroexcitability. It's manage the neuroexcitability. So generally in the management of Alzheimer, these two drugs, this cholinergic inhibitors and this memantine is used. Fine. Now, for new modern discoveries, we have certain new disease modifying therapies. Under these, there are the two drugs. The Decanilab, maybe I am pronouncing it not in the correct way, you just check it. And one is called the Locanilab. These are the two new disease modifying therapies. Okay, so once again, the management of Alzheimer disease relies on the both aspect, pharmacological and non-pharmacological. Under the pharmacological management, we have the classes of drugs. The one is called as the cholinergic inhibitors, which basically inhibit the breakdown of acetylcholine. Under this, the two category comes. One is called as the competitive inhibitors, which will basically, these drugs bind over the enzyme's active site. Okay, and under this, the example is the glantimines. Okay, then we have the non-competitive inhibitors. Under this, we have the two drugs, unknown drugs called as the rivastigmine and donzepil. Okay, then there is one other class of drug which basically manages the neuroexcitability. Okay, and by blocking the NMDA receptor, also called as the N-methyl D-aspartate receptor, and the example is the memantine. Then for the new studies, there are certain drugs which modify the disease, okay, called as the Decanilab and Locanilab. So this is about the pharmacological management. For the non-pharmacological management, under this, the lifestyle modification is one of the thing. Lifestyle modification. Okay, then we also have to advise the patient to exercise. Okay, exercise and Mediterranean diets. Mediterranean like diets. Okay, some paper shows that vitamin E is also helping. Vitamin E supplement. Got it? Then exercise, giving some of the you can say musical therapies, some of the games, like basically engaging the patient. Okay, in the late stage of the Alzheimer, the suicide, okay, or depression is common. Suicide and depression is the common thing. Fine. So this is about the management of Alzheimer disease. Now let's quickly recap what we studied. Basically, we discussed about what is the neurodegenerative disorders, a disorder in which the etiology as well as the pathophysiology is unknown. Fine. And mostly the neurodegenerative disorders are the genetic, but some are the sporadical in nature. Fine. Then we discussed that basically this neurodegenerative disorders, most of the neurodegenerative disorders disturb the protein mechanism synthesis and result into the different diseases. Fine. Then we discussed the classification. There are two classifications. Okay, basically classification relies on which area of the brain is affected. As far as our syllabus is concerned, we have to discuss the two diseases. The one is called as Alzheimer and Parkinson. Then we studied about the Alzheimer in detail, that it is a major cause of the dementia. Okay, and it have both the phase, late onset Alzheimer's and early onset Alzheimer's. We also discuss about their pathophysiology. Okay, their biomarkers. We also discuss the management, diagnostic evaluations. Okay, fine. So in the next video, we will discuss about the Parkinson disease in detail. So thank you for having us. Bye. Have a nice day.